closes. So welcome everybody to this rapid fire entitled Spreading the Safety Net. I hope you all enjoyed your lunch and you're all carved up and ready to go for the afternoon. I'd like to first off say we would like to begin by acknowledging that the land on which we gather is the unceded territory of the Coast Salish peoples, including the territories of the Musqueam, Squamish, and Tsleil-Waututh nations. My name is Matt Brown, and I work for the Ministry of Health. I'd like to welcome all the presenters here and welcome all of you here. For the next hour, you'll hear 3 presentations. They will have 20 minutes each. Within each 20 minutes, they'll have 10 minutes to present. There'll be 8 minutes for questions, and then we'll take a couple minutes just to transition. I told them I would hold them to that 20 minutes.
Sounds like a dare.
Oh.
That's why I took it too. So
Man. Yeah, I know. This is going to be a tough afternoon. Some exciting presentations here, a great wealth of knowledge with our presenters this afternoon. And not only knowledge, but what I've seen over the last 2 days is compassion and passion for the work that they do. So I think you'll see that through in their presentations over the next hour. So without further ado, I'm going to welcome Roy Stanley and Heather St. Laurent for their presentation. Sorry, I just didn't see their names here. Anyway, over to you.
Thanks, Matt. Good afternoon, everybody. My name is Roy Stanley. I am an advanced care paramedic currently posted in Kelowna, BC. I got involved with PSLS about a year ago now after I presented here at Quality Forum, and I'm going to tell you the story of how this all came to be. About 2014, I was working out of Kelowna. I was sent on a motorcycle accident about an hour and a half outside of the community. On arrival, we found a traumatic brain injury, combative, poor airway, just kind of everything that could be wrong was wrong, multiple fractures, and a long run time. We had no air resources available. So we put the patient in the ambulance and we started working. And while I was working, I really came across fear, the great motivator, because as I was looking at the patient, I realized I didn't have the right equipment, I didn't have the right drugs, and I was a long ways from the hospital. So I kind of broke down what I believed we needed to be doing, and I reported it off to, at that time, which would have been prior to PSRO, it would have been the PCQO office. When I reported, I didn't hear anything back. It was quiet. So I called them and I said, yes, I've reported this event. I'm concerned for this treatment modality. What's going on? Oh, we'll get back to you. Well, they didn't. Years went by, nothing changed. I started looking at the process and how it was set up, and it really wasn't designed for me. It was designed for an office. So I started talking to more and more people. I started talking to more paramedics, and I started talking to dispatchers. And I started looking at how the events were coming in. And for 2017, I looked at the numbers, and as you can see there, we had 645 events reported. We had 512,000 ambulance calls. I went, well, we're either the very best in the world or we're really underreporting. So as I looked at the information, I started finding studies, and there were only 2, and there were only one in Canada, one in Europe. It said that every patient contact pre-hospital had between 7 and 14% adverse events. Well, my number shows 0.1%. So we're back to being either the very best or we have a problem with reporting. So after my traumatic brain injury and the frustration that came with it, I came here and I participated last year. And I was introduced to patient safety and quality and Jessica, and started talking about why I didn't believe that the system was working. And we started embarking on how to change it. So my adventure began, and that's about the way it felt on day one. Except you don't see the ground, it's still halfway down. So my goals were to increase the reporting in the service, and to get paramedics involved, because the system is designed for the paramedics and the patients more so than just to be part of a system. So I started contacting different paramedics and different dispatchers that were interested, and we started identifying the ways to resolve our issues, how to get them involved, and how to get the feedback from the system back to them. And we started by sending out questionnaires and talking to crews and developing a brochure on what the system was, how you accessed it, where it was, what it did, what it was expected to do, what to do when it didn't work. So we looked at the how, the when, the why, and what needed to be reported. And then we started classifying it into the different groups. So initially I started with just a small group in my area in the Okanagan, and I went out and I sent brochures to half of them. The other half I went face to face. I went to the stations with the brochures and said, this is what the system is supposed to be doing for us. And I taught it. We increased awareness. The goal for me when I started was 100%. It was 160% by the end of January. The increase in numbers, well, as you'll see in a few slides, has gone through the ceiling and is just climbing. I think this is for you, Heather.
Okay, thank you. Hi, my name's Heather St. Laurent. I've been a paramedic for BC Ambulance for 20 years. I've worked in investigations after that in several roles for an additional 9 years, and currently I've been in the analyst role for 6 years. As far as reporting, by far the most used access point is the direct entry, which was implemented in October of 2017. And that's where the paramedics and dispatchers can directly report events. Since we've gone live with the direct entry reporting, we've seen a huge increase. I would say that at least 80% of our events are reported this way. It's been very effective. The first 3 items on the list take us about 1 to 4 days. Currently, we have 3 analysts working full-time on this every weekday, and we sure could use more people. So it takes 1 to 4 days, depending on the issue. Once the event is handed over to one of our managers, our office provides ongoing support by providing audio, telemetry of vehicle movement, or further event documents as required. And as far as the last 2 items, we like to ensure that all who report in a safety event are followed up with. We try and ensure that patient safety events are investigated fully, and that includes letting the reporter know that what has been done. We do receive a lot of feedback, appreciation for letting them know that they've actually been heard. And these numbers continue to climb. I don't think we are near seeing a plateau in reporting. As Roy was mentioning, the Okanagan Paramedic Group, that the study they did there, that really increased the incidence reporting, more than doubled. Lessons learned. While we're working through growing pains, I don't think it was fully appreciated how much our workload was going to increase. And then we underwent some staff turnover while Roy was out drumming up business in the Okanagan. As far as awareness and usage, we have work to do here. We currently don't have enough staff, have the staffing capacity, but the case has been made for this. We're trying not to sacrifice quality for quantity. We do link similar events together for improvements, and we use code names in PSLS, which allows us to view a bunch of similar issues just in one search. One example, we were noticing a lot of reports coming in surrounding the lack of pain management for our PCP paramedics. By showing that we had a significant amount of issues about this problem, we were able to provide statistics and information so that field studies and trials on other pain management medications have been put in place now. That was one of our wins. Lessons learned. One lesson I learned is that Roy is very devoted to patient safety. I don't know many people who are as engaged. He seems to know almost everyone in the ambulance service, And I have learned that if we don't do a good job, they sometimes call Roy and tell on us.
So that's our recent graph. It was just completed the end of January, and we're currently 160% and climbing, with no signs of us slowing down. Our greatest fear is that if we can't keep up with our reporters, they're going to stop reporting just because they're not getting feedback. So improvements that we've seen, the advanced care paramedics are now on a trial to be deployed into more rural areas. Currently, ALS is only deployed metro urban, which we see as a huge gap because all of our junior paramedics are in small towns. All of our highly trained staff are within 10 minutes of critical care facilities. We've done something backwards, but we've done it backwards since '74, so we shouldn't rush into change. Okay? The trial is live right now in Kelowna. It's live in Abbotsford. As of this morning, Abbotsford's claiming 100% capture of advanced care deployment to high-level calls. We have improved the medications. The ACPs are no longer using archaic medications for induction for intubation. We now have ketamine. We're using fentanyl. We have phenylephrine as a pressor. It's all game-changer stuff. We have pain management for the PCPs in the form of intranasal ketamine and Penthrox. And we're moving forward almost daily right now from somebody who's been in for 29 years. I'm having a hard time keeping up with the change. We've moved more in the last 4 years than we did in the 25 before it. The equipment that we're getting is amazing. We're using a lot of military equipment now for our trauma stuff. We're using ARS needles. We're using good chest seals. It's great because when you're doing trials, if you stick it on your buddy's chest, he is going to scream. We have increased clinical training. I feel I've spent the last 6 months in school. Every time I think I'm at the end of it, they got more for me. It's been amazing. We've increased our one-to-one education with our field paramedic educators. They're out there every day now teaching. Thank you. Any questions? Oh, that was easy. Thanks. Yes.
Thank you so much. This is awesome. I really appreciate you coming forward with that. I'm curious about when you say you direct report. Is it by phone? Oh, I'm sorry. I usually have a really loud voice. So do you do it by phone when you give feedback or when you're reporting? So when you're reporting something, do you do it electronically through a website or do you phone in your PSLS?
It's a website, the PSLS, and all the paramedics and dispatchers have access to the reporting model. So, they come back from their call at 2 o'clock in the morning, they can report right there.
And feedback, is that also through the PSLS system, or do you reach out?
We reach out to them usually by email because I don't like to phone them because they're all on shift work and they really don't like it when you wake them up. Email is, then they've got it. So that's a choice.
Any other questions?
What's your most common PSLS?
I would say ambulance delays.
It was interesting because we went to the call center yesterday, which was really informative.
Up on
No, the
virtual.
MMU.
Oh, okay.
And one of the questions that we had asked as a group was, what is the gold standard for time to get to an incident?
Mm-hmm.
And then driving home from the park and ride, I heard the statistics. So it's 9 minutes in an urban center, and you want to make that 70% of the time, but right now you're making it 50% of the time, correct? That was the statistics out of Victoria. So
Yeah.
Those statistics were part of the study from the Auditor General. That
Okay.
actually went back, I think 2 years ago, the Auditor General started with the data.
okay, so are they accurate? Would you say?
We're much better now. We've actually changed our dispatch center over to what's called Manchester triage, and it's cut our response times down substantially.
Okay.
Thanks, Patricia.
So I'm the chair of,
I'm hoping I'm not in trouble now because she's the chair of the licensing board for our body.
okay, so yeah, I'm the chair of the board that regulates, that has the privilege of working with people like Roy and regulating their licenses. And I am so proud of Roy as being the first everyday champion with the Quality Council. So thank you so much for helping to change the culture within the emergency medical services system in this way. The question that I have for you is that the patient safety learning system sometimes is resisted, I think, because it's seen as a relic of a time when we found fault with individuals who are making errors. And the perspective of the board at the moment is that we're less interested in the errors that individuals make and much more interested in the system that helps facilitate that error, doesn't correct it, doesn't forestall it, and doesn't learn from it. And so I'm wondering if you've built into the work that you're doing, or if you have any plans to do that, to have a much more, and you know, I talk to people within the system and say, well, there isn't time to do the kind of system review that would allow people to be reflective, you know, not of their own errors, yes, but of how the system didn't stop it, didn't facilitate it. Everybody works with a partner. Everybody works with an e-post doc at the end of the phone. Everybody works with an EMR that's about to receive them. I'm just wondering whether the patient safety learning system is a part of the journey towards a systematic approach to error, and I'm confident you've already thought about this because we've had lots of conversations, but just interested in that particular aspect.
Yes, actually we have. Because the patient learning system falls under Section 51, we're actually strongly promoting the fact that reporting is education. It is where we're going to change the whole system for everybody. So if I make an error, and I do make errors, my wife says so for sure, when I make them though, the goal is so my partner doesn't make the same mistake tomorrow. And we're teaching everybody. This is not punitive. This is actually an umbrella to say, hey, I messed up. Teach me. I want to do this better. I want to do the whole system better. And people are buying in. They want to do better.
Yeah, we do get a lot of self-reported errors, which I think is good.
Hi, thank you. Great presentation. My question is, you know, kind of leading off of this, I worked in long-term care, and we had this whole PSL, yeah. And I never, you know, it was on, so say there was a near fall or a near miss, and so we report all sorts of incidents. I'm so curious about this feedback process that you're talking about, because I don't remember people talking about feedback, and is this unique to your department, or, you know, do you, if it was a big event, then, you know, it would be with leadership and you'd have this feedback, but, you know, this individual feedback that you're talking about, is this for every event that is reported?
Every event. It was my goal right from the beginning. My actual goal that we were struggling to achieve just because of staffing, but my goal was within 30 days to have everything reported back to people so that people knew what had happened, whether we were going to change the system, whether we were going to change medications. The only way people buy in is with change.
Yeah.
So yes, you've reported this. Yes, it's important to us, and this is what we're going to do to change it.
Okay, that was my second part. So what was the focus of the feedback? And it sounds like we've received your feedback, thank you, and this is how we're going to work towards helping you to make sure, and the system to make sure that it doesn't happen again. Yeah.
And that's what we've done with the medications and changing our procedures and they're changing right now, like I said, so quickly, that's almost impossible for us to keep up.
Yeah, and so taking that from the individual feedback to more that systems approach, have you been able to trend that data to make those system level changes? Any examples of that?
Yes, because now that we're using an all electronic system, everything's in real time, so we can track everything that's going on.
Yeah, great. That's amazing. Thank you.
We have time for one quick question.
I would like to know where it is that we can report if there is something that I've had people report things to me partner, and I live in a rural area, so where do they?
So is this a patient that's reporting? They can call the patient care quality office. I don't know what the number is off the top of my head, but I know some people in the room do.
Thought because it was the ambulance system that there might be something different.
The PCQO office comes directly into us
Yeah.
and links into this system. So the PCQO is an outside funnel directly into us.
Yeah, and yeah, that
Thanks.
works very effectively.
The other thing is, I want to tell you how much we appreciate up where we live, the paramedics that are working in the community.
Thank you. Did that answer your question?
Well, that's a great way to end that presentation. I'll bring the cash forward to you a little later on. So while we just get ready to transition to our next presentation, just a couple things come to mind just around and the idea of champions that was stolen from me, but just about sometimes the initiatives do take a champion in a community, and the impact of that could be absolutely incredible. And then the other one talked about was just, we have the PCQO and there's complaints. It's a complaints-driven process, but there's also so many opportunities for compliments and to be learning from the compliments as well. So just I wanted to mention that. So moving on to our next presentation, Safety Learning System, Learning from Every Death. Oh, sorry. Yep. We're not on the right presentation. We should be on Safety Learning System, Learning from Every Death. There we go. So I'd like to welcome Camille, Ciarniello, Allison, Muniak, and Julie Bedford for our next presentation. Thank you.
Well, thank you very much for having us. Camille, you're going to stand over and...
Well, ma'am, I don't want to be in front of the screen, and I don't...
She can talk loud. So thank you very much for having us today. We're very excited about this work and the partnership that we have done through Providence and VCH on really bringing interdisciplinary learning reviews to be a priority within our organization. Oh, good, I have the button. Just for our context, how many of you over the past 2 days or 3 days have seen Dr. Jean Huddleston and Camille present? Okay, so there's a few people in the room. So there were 2 presentations that had happened really explaining this whole process. We're not going to get into the details today about it, but what we would like to do is share with you our experience and some of our data that we have captured over the past year. So we have nothing to disclose. So this conversation happened with Camille and I in October of 2017. So this was work that Camille had actually been working on over the past year prior. And right now I'm just totally riding on her coattails because of how awesome this idea has been. But our conversation really started when we had to identify what we were going to recommend for our pay-for-performance metrics for the 2018-2019 year. And we really did not want to do another prescriptive metric like UTI or pneumonia or something that we felt like we weren't actually looking at the systematic components within our organization of how we could drive quality improvement. So we really wanted to find something that was shifting the culture and looking at information in a different way. We knew that there was a lot of really great information that was happening out there, so we were focusing on CS, care-sensitive adverse events, and there was bundles of work that was happening that was working quite well. There was other things that were happening through mortality reviews that were very siloed, our PSLS system, and our critical incident reviews or quality reviews, but there was nothing that was actually linking all of these things together and having those systematic conversations.
And Sir Christopher Ham said on one of the days this week, something that really resonated with me, is that we can create a culture of compliance, which I think is what we've been doing with clinical care management and nurse-sensitive adverse events, or we can create a culture of commitment. And that just resonated with me. That's what I really believe we wanted to build with this.
And so we saw and we've experienced the process that Dr. Jean Huddleston had developed. And so we really wanted to see if we could leverage the Mayo Clinic model within our organizations. And so we proposed it as our P4P metric. There has been a tremendous amount of learning over the past year, but the positive news is that it's working. We have engagement, and what we're going to do is show you a little bit of that process. So our mission, and this is primarily the key thing that we were trying to do, was to actually to find a meaningful mechanism to drive improvement within our organization that looked at the system. So my background, I'm a human factors engineer, and so I'm really looking at complexity and how we actually look at the system and how we drive how people actually work within the system, much of what Rona Flynn talked about this morning, and driving that improvement throughout our organization and ensuring that people are engaged in that process as well. So it was important for us that it was understandable, that it was measurable and improvable, and we wanted to shift that culture. We also wanted it to be a culture of learning that focused on things related to a systematic approach. So things like the system review, which brought all of the information together and everyone would have access to it. Deference to expertise. So we didn't want it to be the quality departments driving the improvement. We really wanted it to be identified by the point of care staff and the central registry and the interdisciplinary conversations, which I think the power in this process has been the interdisciplinary conversations. So I'm going to hand it over to Julie around what we started to do.
So if you went to the earlier talks, you heard Jean talk about how they started with mortality as being their sample of convenience, right? You can get to it, you can get to the charts, and that's really exciting. But we had to find a way to do what she calls the local implementation and making it ours. And so we're going to start with VCH and how we made it ours, and then Camille's going to talk about hers. Because we've kind of gone about it in the same and slightly different ways, and we've got different learnings, as you'll see in a second. So one of the things we did is try to identify cohorts that were really of interest, and we're definitely doing mortality. We've got a whole hospital-wide thing going on mortality, but we heard a lot about individual cohorts that were of interest. And so the very first one that came to light came out of spine, and our spine team being really engaged in wanting to do re-intubation. So all of their high C-spine fractures that had an issue and kept going back and being re-intubated. And so we started looking at those, and we had huge learnings just from there, and that started our journey. And now we've got actually probably close to 8 different cohorts, and we're trying to manage and figure all of this out. But looking at readmissions, sepsis, re-intubation, mental health actually wants to look at violence and aggression. So there's no limit in the areas that you can possibly look at. So our first set of learnings looks something like this. So in the system, and Camille's going to show you some different graphs that can come out of this system, but one of them specifically is this nice little pie graph that's full of information there. But our number one thing that we know we need to work on is our documentation opportunities, followed not too behind by 3 other little bits with treatment and care opportunities, end of life, and then our deteriorating patient opportunities. And each of these you can dive into, and Camille will show that about what you can learn within those. But this is early on. This is very early on compared to what Camille is going to show you. So I'm going to let you talk.
Okay, thanks. There's a database that comes with this, and everybody who reviews a chart simply puts their findings into the database. We sort them out by what are called opportunities for improvement, and those are all themed into categories. So my data is the result of our completion of, at this time, 83 finalized cases. When we joined into the collaborative with Dr. Huddleston in the Mayo Clinic, we made a commitment to reviewing the cases of 100 patients who died, their consecutive deaths. So every single patient who died in my organization over a period of time has had a chart review. Kind of different from what you might normally see, because we will often not review the chart of a patient who came in palliative care and just needed their last few hours for symptom management in the building. We understand why they died, so we don't review their chart. This isn't looking to find out why they died. This is, could we have done any better in their care while they were with us? So what we found in our first 83 cases, not surprising, is the largest category are end-of-life opportunities. These were patients all at end of life. If we were doing a sample of sepsis, we'd probably find something different. But what's fascinating about end-of-life opportunities is that it actually is feeding us information that's really relevant to other areas of issue for us, like flow. So in our first 83 cases, 63 of them actually identified opportunities for improvement. So it's great that there were 20 cases where we reviewed the chart and thought, we did a really nice job there. But in those 63 cases, we found a total of 195 opportunities, end of life being the biggest. And this is what we find in end of life. And we're on a bit of a continuing battle. Every time we get a new case into the system, either goals of care uncertain or symptom management pop up to be the lead. But those two have been fighting since day one. And Jean told me this would be the first thing you would find. Yeah. So something that we've all thought about in the background, I assume for the most of us in the health authority system, we're looking at options for care, most serious illness conversation, really trying to find the best way to have those conversations with patients. Here's the data that tells us that, but more importantly, here are the stories that tell us that. And we've been paying attention to the moral distress of the people reviewing these charts. Because even when the care provided was as good as we think it could have been, we still sit and shake our head and think, we could have done better, and we should have done better. And for those people that this is really meaningful to, we have to do better, not only for our patients, but for our providers as well. We can drill down further. Our second most frequently occurring opportunity is under communication. Nursing concerns not heard by the physician. Now, we're lumping all allied into here because right now the database only has this category for nurses. But we're seeing a lot of cases where SLP on a daily basis are putting notes into the chart saying, we really need to address this issue. We really need to address this issue. And then we're finding that the patient aspirated, and the aspiration leads to pneumonia, and the pneumonia leads to death. These are clear opportunities for us to create quality improvement strategies that are going to make a difference to our patients. Where are we failing? I've been at this for a year. I am still not good at feeding the information back to the units. I'm desperately trying to figure out the best way to do that so it's not just a picture on a wall. So it's my priority for the coming months. We got another exciting work.
Yeah. Great. So we can go tag team this if you want, but the recruitment part I think has been one of the most fascinating parts, and recruitment and engagement with this process. What we started with was a goal of doing 100 consecutive cases at each of our health authorities. What I didn't appreciate was that we actually needed to slow it down within BCH, pause, and really be intentional with our engagement. And so we actually stopped and we started having engagement conversations with our physicians and our point of care teams. And that has been the most powerful piece. What we started with was actually having a small group of us going over down the street to St. Paul's Hospital and actually going and watching their interdisciplinary review committee, which they call Chart Club. We call it our interdisciplinary review committee. And what these are actually monthly meetings, now that we both have them up and running almost. We're almost there across our health authority. Our last group, which is going to be Coastal, is having their first one next week. But basically what we have found is we have almost 40 to 50 people in a room from all different disciplines having a conversation about the same case without blame language and talking actually about the system opportunities that can fix, that can be identified that we can then potentially be focusing on to fix within our environments. So we have spent a tremendous amount of time focusing in on that engagement piece. The other piece that has been extremely important for us is actually having physician and point of care team leadership within it. And so we aren't the ones that are actually running and facilitating these interdisciplinary meetings. They're being led by our physicians. There are a few physicians that have actually stepped up and are leading these on a monthly basis, and nursing teams as well, and allied folks who are actually involved in the process as well. Anything else? Yep. Time? Oh, yes. Do you want to know my last pitch? So I'll put Matt on the spot right now, because what Camille and my vision is that the power in this, so some of the cases that we have seen, and I think this is where there is a difference between what we see within PSLS and what we see within this process, is that there's been a few cases that have really stood with me where we've actually seen a patient's journey, say over the past 10 months, transition over 3 or 4 of our health authorities within the province, end up dying within VGH or St. Paul's or another hospital within our health authority, but that patient has actually gone through their last 10 months of their life going through all of our different health authorities. And so the opportunity that I see there is that this could actually be a provincial way of learning and us being able to share and actually focusing on the patient and the patient's journey throughout our system collectively.
The cases that have caused us the greatest moral distress were the ones where we brought patients down to St. Paul's for a sort of a real Hail Mary kind of procedure, and there's nothing wrong with that. But sometimes they get there, and when we have the conversation, it turns out they really don't want to go ahead. And there's not a good way for us to have those conversations from a distance. And sometimes they're dying without their families around them. Mm-hmm. And it tears us apart, and we want a way to actually be able to solve the bigger system issues together. And we want to put that call out. We think this is doable in every health authority in British Columbia. And we're really keen to hear the interest. We've had lots of conversations in the last couple of days about people who really want to come on board, and we want to encourage you to do that.
Mm-hmm. And we invite you to come to our interdisciplinary meetings if you're interested. We have started bringing patients and families into those meetings as well. I know I'm over time, I'm sorry.
No.
But yes, the invitation's open if you're interested.
Julie was just saying we never stop.
Oh yeah. You talked about passion.
I know, this is true.
And
So, excellent, thank you.
You're
Thank you
welcome.
for your presentation.
Yeah.
Questions from
Yes.
the group?
Wow. Just love. I'm sat here and probably made my conference as much as you say. I'm really interested to know in how you've used your engagement to overcome some of the, I'm going to say, inherent suspicion that we have when we talk about mortality reviews, reviews of cases, that, and I'm speaking from experience and with the greatest respect to physicians that I have worked with, where it has been a predominantly physician-led review, and there has been a reluctance, in my experience, of other members of the healthcare team to participate in those reviews because they see it as a very medically run review, and a lot of it's done behind closed doors. I would love to know how you were able to break those barriers down and to everything on a flat level so that everybody felt included.
Alana, can I put you on the spot? So I see one of our reviewers, and then
And we need to repeat the question because we're being webcast.
Okay.
So the question is, how have we got past the suspicion, some of the suspicion that's been historically connected with M&M and the lack of inclusivity with the whole healthcare team?
Okay. So Alana is one of our nurse reviewers within BGH.
So if I wasn't paying as strict attention if I knew I was answering this question, but if I think, I think I get
Totally
the idea. So I think the structure of the learning review is very specific, and it's set up to flatten the hierarchy. Everyone has the opportunity to, so a nurse reviewer and a physician reviewer can do it together, or they can do it separately, and then they enter their data and their findings separately, and then they're discussed as a group. So what that gives is the opportunity to, everybody gets, it's kind of like the talking stick idea, everybody gets their time to present their perspective to the group, and it's considered as a group instead of having one profession sort of run the whole show.
I do want to add a couple.
Yeah.
So I would say another few things that happen. Dr. Huddleston is a huge nurse fan.
Yeah.
So when we do the reviews, one of the things that she actually tells us to do is to focus on the nursing notes. And what I've heard from my physician colleagues is absolute amazement. Some of them didn't even know where to find them, and they're shocked at the depth and richness of information in there. And they also recognize, because when they say, how do I know it's a nurse? They'll say, well, they're the one who date and time their entry. Yeah, and the writing's legible. So there's already a bias towards the nursing perspective. But then that idea in the meeting, Jean really likes the nurses to do the case presentations and to speak first and to talk about their opportunities. And then there's an opportunity for everyone in the room to come to a better understanding. And many of our physician colleagues have not been aware of some of the frustrations or struggles that the nursing staff manage or cope with hour after hour, minute after minute in their days. So there has been so much bilateral learning, I would say, in those reviews, and it's just been remarkable. We have not always been successful. I've had nurses come to me afterwards and say that they didn't feel their voice was heard, and we work on that at the next meeting. But it is always the idea that everyone comes with an equal voice. And I said this yesterday, people may have heard, we've had a case, many cases, the physician will present the case presentation and then say, I didn't find any OFIs. And then the nurse will say, well, it's okay, I found 15.
Yeah.
And it's the idea, we're not meant to find the same things. That's why we have two perspectives, and both of them are equally important.
Wonderful. We've run out of
Thank
time.
you.
I'm sorry, folks. But thanks. Allison did throw the pitch to me just before the presentation, and suffice to say, I think I was sold yesterday or on our first day, for those of you who went to the Learning Health presentation. I was certainly sold then, and I am now, and I'm excited to work with Allison and Camille and anybody else, because I do think there is this is fantastic, and I think there is considerable opportunity here. So thank you. So for our final presentation, I'm on Safety Passport, promoting patient safety for healthcare providers. We have Fabio Feldman and Javairia Raza from Fraser Health.
Perfect. Thanks, Matt. Hello, everyone. We're going to shift gears here a little bit, and we're going to talk about our Safety Start With Me campaign that we developed at Fraser Health. We have nothing to disclose. And so in Fraser Health, we've developed those patient safety priorities. So we had the first one in 2016 to 2019, and now we're on the second phase of our patient safety priorities. And patient safety priorities are basically, we as a committee, we went through a lot of types of incidents that can harm patients. It was actually a list of over 64 types of incidents, and we tried to narrow down to what are the key ones that we should focus, because those are the ones that are really harming our patients. So we've went through a whole process of narrowing down, and the ones that we have for 2018 to 2020 are MRSA, hospital-acquired UTI, pneumonia, delirium, sepsis, and the 10-hour rule in our ER. So 10 hours, the patients have to be admitted before 10 hours in the hospital. So those are the ones that we're focusing on. And we develop a whole campaign that is to foster that knowledge and to touch into patients and families, and also to provide education to staff on understanding what are the priorities, what are the works that we can do, and how can we're going to be able to engage patients and families in that process. So like I said, with the campaign that we have, and you all on your seats, you can have you have examples of some of the material. We have two streams, one that's specific for education for the health professionals, and the other one is for awareness for patients and families. I'm going to go over a little bit about the patients and family portion, and Javairia is going to go into more details on our passport. That's the education for the staff. So if any of you were at the presentation this morning with Kevin Hare, he was talking about back to basics. And that's what we're trying to bring here is what are the 5 things that can keep someone safe in the hospital, right? And those are basic things, including keep clean, know your medicine, get moving, ask questions, and plan for home. And that's the information that we're sharing of our health professionals as well. And we have lots of different ways that we spread in this knowledge. One of them, is a brochure that you have in front of you. I'm sorry, that one is in black and white. But the one-pager, it's a little bit more, a little bit of details on this. And we have tabletops with that information that we put across all our hospitals, in our cafeteria, in other areas. That talks a little bit about each one of those 5. Most of the hospitals now, you're going to see elevator wraps with that information, unit station wraps right in front of the unit stations of each unit, and as well as those brochures and information. So we're trying to put out there as much as possible. And we even approaching our volunteer services to provide those brochures and to have those discussions with patients and families. And the last thing we did is we refresh our quality boards. So the quality board that you see in there in front of 2 of our patient advisors, we have one of those at the entrance of each unit in all the hospitals in Fraser Health. So one of the inserts in there, you can see, is our 5 steps to keep safe in the hospital. But we also have information on our share commitments. We have the names and photographs of the manager and PCC of the unit with their contact information. So if the patient families, they have any questions or concerns, they know who to talk to. And a little bit of data on our patient safety priorities that's specific to the site, right? So we provide rates of sepsis, delirium, all of those into that in a way that is, it's not the simplest way for people to understand, but it's much easier than some of the other type of data that was being supported before. I'm just going to pass to Javairia to talk about the other side of this.
Thank you, Fabio. So I'll be talking more about how we're engaging our staff with our patient safety priorities. So the question we're literally asking is, how can we use technology to increase healthcare provider engagement in patient safety? We know that healthcare providers are engaged, but this is just an added complement, how we can use technology to improve and already complement their work. So here's what we came up with. This is our safety priorities passport, as you can see. Fabio's popping up right there. Unfortunately, that's not in the passport, but this is just an example of the technology that we are using in there. So the Fraser Health Safety Priorities Passport includes 3 interactive aspects. It has statistics and learning activities, it has images, and I think the most exciting part are the 2D, 3D augmented reality graphics that we worked with Microsoft to help us develop. So I'll be taking you through some of those specific things in the next slide. So at the top, each priority has its own designated page, and at the top you'll find a statistic related to that priority. So this was sort of current data at Fraser Health when we were developing this material, as well as some information from the literature. In the middle, you'll find an image, and it was carefully curated alongside our patient safety priority leads. So they're really the ones who are the experts of each priority, and they're making these recommendations along with helping us develop these images. So these images are reflective of maybe best practices around the priority, or maybe conceptualizing what we mean by this priority, as you'll see later on. And at the bottom, there are learning activities. So we asked our patient safety priority leads if there were 2 things that you would recommend for your staff to know about the patient safety priorities, what would you tell them? And then they told us what they were, and we put them down, and then there's a place for people to date and put in initials for if they've completed their work. So we wanted to make sure that the learning activities we provided were accessible and easy for the staff to find. So we have a curriculum called Safety Passport on Learning Hub, which I believe is used by a lot of our regional health authorities. And essentially it is a compilation of all of the courses that we recommend and any recommendations that the learning activities recommend that are not a part of Learning Hub are provided as links in the description, are available on Fraser Health's intranet website. So this is about making sure that this is available online, so it doesn't have to be something that you have to come in and do, taking time out of your work and work shift, and making sure that it is easy to see. I wanted to highlight some of the images in there before we move on to the augmented reality graphics, because we spent a lot of time with the illustrator developing this work. And as you can see with, for example, MRSA, this is, for example, as I mentioned, some of them around best practices. So you can see it's the staff member recommending to the patient to wash their hands. So for the pneumonia one, some of them are like deep breathing and coughing with like the elevation. For delirium, sort of reflecting the fact that if you're doing all of these things, the patient is happy and not delirious. I may be wrong about this. I'm not a clinical background, just want to preface with that. And then for sepsis, we have some of the indicators around sepsis to look for. And then here's some of the conceptualization of the 10-hour rule in emergency, just talking about how hours really affect outcomes. And then we have UTI as well. So this is the example of an air graphic. I promise you it looks a lot better when you're looking through it through our app. The instructions are available within the passport that you'll find on your chair. And after downloading the app, you can point it at the passport. So what we wanted to do with this was not focus on just having a pretty picture. We knew this was going to be a memorable part of our booklet, so we wanted to be action oriented. So we went back to our patient safety priority leads and we said, if there was one thing that you want patients to take, staff to take away from this booklet, what would it be? So for pneumonia, the lead came up with, get your patients to brush their teeth at least 2 times a day. So if you don't take away anything else, at least you take away this from the passport. Quickly just wanted to go over some strategies that we had related to this. So where the CNEs and the managers are currently using, and these within their sessions, they're hosting sessions and education workshops where they encourage people to use their passports, and because the curriculum is available on Learning Hub, management is able to track it, so we promote this as something that people can use for professional development. These are, again, the passport is accessible through Print Shop and the intranet page. The passports have been provided when we presented this work at the Patient Experience Conference last November. And the passports are also, and as well as the patient-facing material is brought up at the new employee orientation. So as new employees are coming in, they're automatically introduced to the patient safety priorities right then and there, and they know that this resource is available to them for them to use. I just wanted to bring this up. This is one of our one-word feedback from our Patients Experience Conference related to our app, which I'm sure you'll get to download yourself later on. Just to say that we are in the process of evaluation right now and getting feedback. So if you have anything you'd like to say, please, we welcome all sorts of feedback, as well as to say that this is a 2-year initiative, and we are constantly in the process of growing this work, that it is not static, and we're just going to do our best until whenever to make sure that we are doing the best we can. Okay, this is our time for discussion, but we wanted to also, if you don't have a question, feel free to download the app it's called Safety Starts With Me Passport. It is available for free on Google Play or Apple Store. So if you don't have a question, please feel free to look at the air graphics. You don't even need the booklet itself to download, or so to see the graphics. You can see them just through the app itself. Yeah, thank you.
Of interest, Fabio just showed me actually how to use it over here, and it's actually pretty cool. So I give that a plug as well. So any questions from those in the audience?
So one of the things you're focusing on regular sort of frontline staff. Are you doing anything to engage physicians with this learning because they don't get this?
Yes. So good question. We had, when we launched this, we had a whole symposium around that, and we had a few physicians involved as well. And they really like this. They learn quite a bit from the passport. So we do have some initiatives to share that with the physicians as well, to learn, but not only through the passport, but a lot of work through the patient safety priorities, so that they are aware. But it's definitely a group to get involved. Just want to add one thing with the passport itself. The way that we try to approach this is for the passport to be, and it says right there on the front, it's a component of their professional development, right? So as they go through the learning hub and complete this, whenever they go for their recertification process, they can use this to prove that they've had all the learning. So this is just a way to make it easy for them to learn about the patient safety priorities, but also use that learning for their profession.
Excellent.
Okay.
Thanks to you both.
And if you don't have the app and want to see, just come and see me. I'll show you.
Thanks, everybody. That hour went so fast. Just think a couple other things came to mind. Just it's amazing how relevant and transferable a lot of the things that we've heard today can be within your respective hospitals or your respective health authorities, and that's certainly a takeaway from here. And also, we've heard a lot the last couple of days just around culture, and certainly the culture of learning, culture of sharing, and sharing from one another, which was very clear in this. So before you head off, though, a couple things. One, your forms, your thank you, evaluation forms. Please take the time to fill out your evaluation forms. There's two ways you can do it, either in paper form, which they'll hand out at the back of the room, or you can do it on the app as well. It's another option. Secondly, we have one last plenary. I think we have about a 15-minute break between, or maybe a 10 or 15-minute break to grab another coffee if you haven't had enough coffee in the last couple of days. So I think that starts at 2:45 downstairs in the ballroom. So thanks, everybody. Safe travels home and enjoy the last presentation.